So what I'm supposed to discuss on the new drugs and technology for diabetes mellitus and the game changers. So I think the main issue, as I've discussed before, is that for people who fast during Ramadan, is that this is the pattern between the glucose pattern throughout the day between patients who have diabetes and the various types of medication, such as they are on metformin, gluten, and insulin, and so on, and those who are normal. And this is a non-fasting period. As you can see that for this is for the non-diabetic patients, and these are for patients who have diabetes on various forms of medication. So in the non-fasting period, the profile throughout the day is quite similar. And even though, of course, the overall blood glucose is higher because they have diabetes, but there seems to be fairly constant throughout the day. They maintain the blood glucose within quite a narrow range. But what happened during Ramadan is that the variation in the blood glucose tends to be much higher. Okay? It starts at the day with the sahur, where there is a peak, and then afterwards it comes down as the patients fasted, and it comes to be quite fairly low just before iftar. And with iftar, with the break of fast, then there is an increase in the blood glucose level, and it remains fairly high throughout the night because people continue to eat. So you have a very wide variation in the blood glucose during fasting month as compared to the non-fasting month in people with diabetes. And of course, it's worse, especially if the patients are on insulin. So this gives rise to the problem that people with diabetes who fasted during Ramadan, in the sense that they have hyperglycemia and hypoglycemia because of the daytime fasting and the nighttime feasting. And because of hyperglycemia, people type 1 diabetes are at risk of getting diabetic ketoacidosis. And of course, when people are fasting, they have also fasted from taking water, and hence they have a risk of getting dehydration and thrombosis. So if we want to have our patients who are able to be fast fully without any problems, then we have to address this. And medications and devices are important in making sure that we can avoid these issues, and hence our patients should be able to fast safely. So the so-called the game changer, in fact, of trying to get people to fast safely during Ramadan. So we'll start off as trying to reduce, I could just go through very briefly to the oral agents, going to some of the studies, reviewing the studies in terms of making the studies that show that certain drugs have very low risk of hypoglycemia, and hence their patients are able to fast for most of parts of the month of Ramadan if they were to take this medication. So the DPP-4 inhibitors that have been around for some time, quite new, have been shown that they can reduce hypoglycemia. Okay? Sitagliptin, for instance, have been shown from the Al-Sifri study a lower risk of hypoglycemic events in those that were treated compared to those who were treated with SU. And also, they also had fewer symptomatic hypoglycemic events versus SU, 6.7% and 13.2%. So more patients on sitagliptin were able to fast more days compared to SU because they have less hypoglycemia. The Aravind study on similar shows that patients on sitagliptin had lower risk of hypoglycemia than those treated with SU, and they also associated with fewer symptomatic hypoglycemic events. And hence, patients on sitagliptin in this study were able to fast for more days compared to those who were on SU. The other DPP-4 inhibitor that was studied was vildagliptin, and then also vildagliptin and the ARUJ study, for instance, they had fewer symptomatic hypoglycemic events with vildagliptin versus SU, 5.4% versus 19.8%. SU was associated with an increase in HbA1c, whereas vildagliptin was associated with decrease in HbA1c, suggesting even with less hypoglycemia, and also has a better tendency to improve glycemic control during Ramadan. And there was also a greater decrease in body weight with vildagliptin compared to SU, again showing that the benefit is not only in getting less hypoglycemia, but slightly better glycemic control, but also in weight reduction. The Devendra study also showed that patients have less symptomatic hypoglycemia with the vildagliptin compared to SU 7.7% versus 6.1%. I think more patients were able to fast on vildagliptin compared to SU. Other studies with vildagliptin, such as Halimi, show also fewer episodes of severe hypoglycemic event with vildagliptin as compared to SU glenide, 62.6% versus 10.4%. And of course, Dr. Mohamed Hassanin have also showed that vildagliptin in this study in 2011 associated with fewer hypoglycemic events compared to SU, a reduction of 41.7%. And HbA1c was also lower compared to SU, a minus 0.5%. And also Dr. Mohamed Hassanin again in 2014, also with vildagliptin, also showed that the vildagliptin had fewer hypoglycemic events compared to SU, 3% with vildagliptin compared to 7% with SU. Okay. Other studies with vildagliptin, MAHA 2014, they didn't have any difference as far as hypoglycemic events between the vildagliptin and metformin. Perhaps it depends on the SUs with SU that they were using in this. And for body mass index, vildagliptin was associated with a decrease, but SU was associated with an increase. So again, showing some benefit on weight reduction with vildagliptin in this study. Yeah? And Shetty in 2013 also showed no differences between hypoglycemia between vildagliptin and SU. Again, perhaps the SU they were using was slightly different compared to the other studies. There was an improvement in glucose control. The A1C was decreased in the vildagliptin compared to the SU group by minus 0.43%. And the body weight was decreased with vildagliptin minus 1.2 kilogram compared to weight reductions of only minus 0.03 kilogram with SU in the study. So again, like other studies, show some benefit for weight as well with use of DPP-4. So again, in essence, DPP-4 has been shown to reduce the risk of hypoglycemia compared to SU, enabling patients now to fast for more days and instead of breaking fast because of hypoglycemia. So again, a benefit for if patients will be put on DPP-4. Now, the other agents with the SGLT2 inhibitors, the first is dapagliflozin, showing that dapagliflozin has a lower risk of hypoglycemia, 6.9% with dapagliflozin versus 28.8% with SU, again showing that more patients were able to fast for more days with SGLT2 compared with SU. And Dr. Mohamed Hassanin again in 2017, he studied canagliflozin. Symptomatic hypoglycemia was 3.7% with SGLT2 versus was much increased in people with SU, 13.2%. But I think the caution was that there was more hypovolemia with SGLT2 versus only 5% with SU. So even though dapagliflozin causes less hypoglycemia, makes patients be able to fast for more days compared to SU, but caution of hypoglycemia or hypovolemia dehydration with SGLT2, caution on that. So there are only 2 studies with SGLT2 for Ramadan that I can find. Now we go to the injectables, okay? And as been mentioned by Dr. Zanaria earlier, insulin analogs have been shown to be much better compared to the conventional or human insulin because they are safer as far as the hypoglycemic risks are concerned. So in general, people tend to recommend insulin analogs in Ramadan because there's less risk of hypoglycemia, enabling patients to fast for more days. And then Dr. Zanaria has also talked on the use of the newer insulin, the longer-acting insulin, degludec. But the study has been described by Dr. Zanaria again, by Dr. Mohamed Hassanin, the use of the IDAC-UPS combination of long-acting insulin degludec with aspart, showing that in general there is a 74% reduction in terms of hypoglycemia as compared to the biphasic insulin aspart or Novomix. So again, showing again more patients were able to fast with this new insulin compared to the older analog insulin. Coming to the GLP-1 receptor agonist, again showing that here's some benefit for people with diabetes, less hypoglycemia, enabling patients to fast for more days for safely. And for liraglutide, the AZA in 2015 showed that there was fewer symptomatic hypoglycemia with liraglutide compared to SU. And there was also benefit as far as glycemic control. There's a greater decrease in A1C as compared to SU, so less hypoglycemia, fewer hypoglycemia, better glycemic control, and the body weight was also much decreased in patients who are on liraglutide compared to SU. Again, has some benefit on weight as well. And Brady in 2014, when looked at the hypoglycemia as defined by blood glucose of less than 3.9, there were fewer events on liraglutide as compared to SU, and the A1C was also greater reduced compared to SU, and the body weight also greater decreased compared to SU. So at least liraglutide has been shown that in Ramadan, you have fewer hypoglycemia, patients were able to fast for more days, better glucose control in terms of H1C, and also better weight reduction as most patients are obese. So there is a added benefit of using GLP-1 receptor, in this case liraglutide, in Ramadan. For lixisenatide, I think again, Dr. Mohamed has shown that in a study that he did comparing lixisenatide with the basal insulin compared to SU with basal insulin, there were again fewer documented hypoglycemia, 4.3% versus 17.4%. Okay, again, patients were able to pass more days with lixisenatide and insulin versus SU and insulin. And SAI, which is the same, which is an Indian cohort of the same study, which Dr. Hassanan was the lead investigator for multinational study, where in the Indian subgroup analysis, again, similar to the main finding that the hypoglycemic event was much lower with lixisenatide plus basal insulin as compared to SU plus basal insulin, 1.3% versus 14.7%. And I think Dr. Hassanan has talked briefly on this, the fixed ratio combination of lixisenatide versus glargine in this earlier presentation just now, showing that with this combination, that the patients were able to fast for more days, or for about 28.7 days, so nearly 1 full month, and only 5.9% broke the fast, okay, as described by Dr. Mohamed Hassanan just now. Okay? And the symptomatic documented hypoglycemia was only 2%, and there's also improvement in HbA1c of minus 0.8%, and also in fasting plasma glucose, a reduction of about 24 milligram per deciliter. Okay, like similar to liraglutide, use of GLP-1 receptor agonist is not only to reduce hypoglycemia, but may improve glucose control during the month of Ramadan, and also here they mentioned weight, perhaps some weight benefit as well. Okay, now we come to devices. Now was on drugs, now devices. Insulin pumps. Okay? Again, some of the review on the use of insulin pumps was that Al-Maudi showed that more patients on insulin pump than patients on multiple dose insulin regimen were managed to fast fully during the month of Ramadan. Okay? 31% versus 22.1%. Okay? And the use of insulin pump was associated with less glucose variability. So you don't get the glucose variability that you get, as I showed in my first slide, that you see in people with diabetes, especially if they're on insulin. They have a very wide variability. Okay? And on Howley, in 2009, this probably I would say a pilot study looking at 5 patients who are in insulin pump. They detected there were no cases of severe hypoglycemia, and many of these patients were able to fast fully or fast more days during Ramadan without severe complications. Al-Aga in 2017, comparing between pump and multiple dose insulin, showed that the percentage of patients who broke fast on the pump was 41.9% compared to those on multiple dose insulin injection was 60.9%. And pump users were less likely to break the fast compared to the multiple dosing insulin due to hypoglycemia. Again, showing an advantage that perhaps pumps with less hypoglycemia and patients will be able to fast for more days without hypoglycemia. Another studies, Benbaka in 2010 showed that this was more of an observational study, that people on the pump were 61.2% can fast the whole month without problem. So they were able to fast fully for the whole month of Ramadan without problem. 18.4% fast between 27 to 28 days, 16.3% fasted 24 to 25 days, and 4.1% fasted 20 days. In general, all patients were able to fast more than 20 days if they're on the pump, compared to perhaps when they were on the in the multiple dose injections before. And nearly half the patients decreased the basal insulin by 5 to 50%. So generally showing that both on the pumps, they require lesser basal insulin. And fasting was broken only in about 55 of the 140 potential fasting days, 3.8% only. So many of them were able to fast for the full month. And no severe hypoglycemia reported in any patient. And hospital visits was reported only for one patient for hyperglycemia, and that was because she disconnected a pump. So again, in terms of the resource utilization, hospital admission was also less those pumps. And for the patient that had the Ramadan procalcitonin level measured, there was some improvement in the procalcitonin level, showing that then with the pump, you may get some, not only less hypoglycemia, but perhaps better glycemic control during the month of Ramadan. And Khalil in 2012 also showed that patients were able to fast a median of 29 days, so nearly 30 days for the patient these patients on the pump. And the total insulin administered during Ramadan was not different from pre-Ramadan, so the total daily dose was the same, but there was a difference in the pattern. Most of the patients require lesser basal insulin compared to before Ramadan, but the daytime was less, but the nighttime was higher simply because of the increase in eating during the nighttime. And found that the larger amount of insulin boluses was given at iftar, fawala, and sahur. There were no major hypoglycemic episodes reported, and the minor hypoglycemic episodes were equally distributed. And that's probably either because of the during the both daytime and nighttime. Now there's a new device with the insulin pump with low glucose suspend. And this study, what they did was they had patients who one had the pump when they on the glucose suspend, and the patient that had the off low glucose suspend. And they found that those who had the low glucose suspend on, there was a meaningful reduction in hypoglycemia, and that was significant compared to those that suspend the low glucose suspension mode. And the hyperglycemia was also reduced. And so not only hypoglycemia, but hyperglycemia was reduced if you have the low glucose suspend on rather than off. And there was they concluded that the low glucose suspend insulin pump significantly reduced exposure to hypoglycemia, and there are no patients on the low glucose suspend insulin pump broke the fast, whereas 15 in the low glucose suspend off broke the fast. Again, showing that with this new so-called application on the pump, patients were able to fast during Ramadan fully, type 1 patients, and they're very high risk of hypoglycemia and hyperglycemia. CGMS, showing that again CGMS are very useful for diabetes in fasting because showing that patients can adjust their insulin during fasting. So CGMS and this study can increase the confidence of patients who fast during Ramadan. And AGA in 2017, when patients who were on the flash glucose monitoring, they found that no severe hypoglycemia reported because the patients actually used the reading to adjust the insulin doses. So it can be used successfully in adolescents with type 1 diabetes. So the use of CGMS and pumps, okay, this is from a review, that the use of continuous glucose monitoring or flash glucose monitoring along with pre-Ramadan structured education can enhance advantages offered by continuous subcutaneous insulin infusion and during Ramadan, helping patients to fast successfully and safely. Okay? And using the low glucose suspend function in the CSRI system can further improve safety of fasting in adolescents and young adults. And the hybrid closed loop system can offer improve safety and improve glycemic outcomes, because we probably do not have a fully functional closed loop system there. So we may have a hybrid where some of the input will be added manually through some form of algorithm. So in conclusion, then, ladies and gentlemen, the risks of fasting and Ramadan are hypoglycemia, ketoacidosis, and dehydration. And newer agents and devices can reduce the risk and enable patients to safely fast, as I reduced in terms of drugs and devices. And the DPP-4 inhibitors as GLT-2 inhibitors, GLP-1 receptor agonists have low risk of hypoglycemia. And insulin analogs are preferred over conventional insulin regimes if they have lower risk of hypoglycemia in fasting. And frequent plus glucose monitoring is fundamental to ensure safe fasting. And the use of continuous glucose monitoring or flash glucose monitoring is superior to self-monitoring of blood glucose and should be monitored method of choice if feasible. And the CSI, continuous subcutaneous insulin infusion with low glucose suspend function or closed loop system can improve safety. Thank you very much for your attention.